So hello and welcome back. Time has flown by as we embark on our fourth and final COVID-19 and uncontrolled hypertension learning and action network. As many of you know, my name is Caitlin Conway and I am a chronic disease and patient family engagement lead here at Mountain Pacific Quality Health. Throughout the last 2 months, we have continued to learn more and more every day while simultaneously seeing increases in cases across our region. Before highlighting the current COVID-19 numbers, I would like to introduce today's presenters. First, let's welcome back Stevie Tsai, pharmacist and senior account manager at Mount Pacific Quality Health. Stevie continues to work closely with various partners throughout our region to share knowledge and increase participation from pharmacists and primary care providers in quality improvement. Joining Stevie today is Amber Rogers, who is also with Mount Pacific Quality Health. Amber Rogers is a registered nurse and she has been an employee with Mount Pacific since 2015. Her responsibilities include development of community coalitions to decrease gaps in care transitions, navigating the healthcare transition from volume to value, and implementing strategies to improve prevention and chronic disease outcomes. Prior to employment at Mount Pacific, Amber was a director at a physician hospital organization, and she has also experience as a nursing director at a PPS hospital with a variety of clinical departments and as a chief nursing officer at a critical access hospital. I welcome both of our presenters, and Stevie, the stage is all yours.
Thank you, Caitlin. Thank you everyone for being with us this Tuesday afternoon or Wednesday morning, depending on where you're at. We do have the same objectives today that we've had throughout our series, and skipping through things. And I just wanted to kick us off with our COVID-19 regional update. If you follow the news around COVID-19, you are aware that we are up in COVID numbers in 32 states. Our states and our region and our territories are no different from that. We are definitely seeing some trending that is indicating that we have widespread community transmission, increased test positivity rates, and things that should be capturing all of our attention. Also, interestingly, since we met last time, the Pew Research Institute has been conducting some lay people studies to see what everyday Americans are feeling in terms of COVID vaccination. I think we're all pretty aware that the COVID vaccine, when it becomes available, is really going to become part of our comprehensive strategy to getting through this pandemic and reaching the other side where we can remember it in the past rather than live it every day. And fewer than 25% of Americans are prepared to take that vaccine when it is ready. So as we talk about COVID and our other chronic diseases, don't forget to think about what you have in your tool belt for vaccine hesitancy, because it's really going to be key as we move further into the COVID-19 pandemic. With that being said, if I can get our next slide to load here, sorry about that. We have updates for Alaska and Guam to kick us off. Alaska didn't have their new cases update ready to go prior to us rolling out today. There was a small delay. Usually that tells us that they're cleaning data still, but they are seeing active cases decrease. Those new case rates are going down over the last week or so. They have seen 13 deaths in the last 2 weeks, and we're seeing an increase in that 7-day test positivity average. And so that is just the total number of tests we give, how many of them come back positive. And it gives us an idea where we're at in the pandemic and how many other diseases or like viral upper respiratory infections we have floating around, because the differential diagnosis is very difficult. Guam is also still seeing a slight uptick in their cases. They've seen several deaths over the last 2 weeks, and they are still seeing increased new cases. However, it's not quite as dramatic as what we were seeing in August. Same goes for Hawaii. They currently have our best 7-day positivity test average at 2.6%. We'd really like to see those start to drop below 2, but as we approach sort of COVID and influenza season, along with RSV and just traditional upper respiratory infection seasons, as we all start coming inside more, we're going to see those things swing up unless we really focus on our preventative measures, which would include masking, hand washing, and maintaining social distance. Montana definitely is starting to come onto the radar nationwide in their number of new cases per capita. They have a really large growing number of active cases, seeing large outbreaks in several of their areas there, and their test positive rate jumped up to 7.4. Northern Mariana Islands is still doing a great job hanging in there, keeping their cases low. They are still seeing 1 or 2 cases here and there, but no widespread community transmission there. American Samoa still does not make the list. They are still holding strong as the only territory in the United States to not be impacted by COVID-19 at this time. And then last year we have Wyoming, who is leading the pack in our 7-day positive test average rate at 14.47%. We're seeing widespread active cases in many areas, primarily linked to restaurants and other leisure establishments like bars. And we are seeing increased numbers of hospitalizations across all of those states as well. So definitely things to keep in mind, and be sure to know the numbers in your area as well. As we move into influenza season, capacity of our medical facilities is going to become very critical. It's important to start getting people vaccinated for the flu. The goal of this year is prevention. With that, I am going to pass things over to Amber Rogers.
Sorry, I forgot to unmute myself. You would think with all of these Zoom meetings, we would all be experts by now and not need these reminders. So now we'll get into the hypertension aspect of this webinar. So next slide. So many of you likely have seen this graphic from the Million Hearts program. Million Hearts actually started this project to decrease cardiac events in 2012, and we are now at 2020, and we still have a huge lift to go. Of all of the patients that have hypertension, only about half of them are currently being treated with medication. And only 1 in 4 of those people that are actively being treated have controlled hypertension. So there are still many, many interventions, public messaging, care coordination, all types of different resources that we need to do to counteract hypertension and get that under control. Because as we know, the side effects and sequelae of hypertension are quite devastating to our healthcare systems, as well as to families and patients. So one of the things, next slide, please. One of the things that we did when we looked at your registration, we asked you to complete a poll during your registration. And we asked, what kinds of interventions have you already implemented within your practice? So quite frankly, it's you guys that should be telling us your stories, your success stories. And I just want to bring up a few little things. Number one, 53% of the folks that registered for this have implemented telehealth. That is extremely important during the COVID-19 pandemic. So I appreciate everybody that rapidly implemented those processes. The next thing that not almost everybody, but a large majority of people implemented was self-monitored blood pressure. This is really ensuring that patients have the ability to either purchase or loan blood pressure cuffs, teach them how to do them correctly, and report back to the team with the chronic care management, which was also neck and neck. Other slower to implement things were your risk stratification and your blood pressure protocols. And those are two very important levers as we continue to improve our results. So folks that have implemented those procedures, we would really like in our sharing time for you to feel free to speak up. And remember, always feel free to use the chat. If you have a particular resource that has been super helpful for you, or some nuggets to share, please include those comments in the chat box. Next slide. One of the first things in, I don't know how many of you have actually looked at the Million Hearts Hypertension Change Package, but in every change package, it doesn't matter what the topic of conversation is. You must have a provider champion and the ability to track data. As you know, the old saying is, if you don't know where you're going, any road can take you there. So understanding the leadership needs of each organization, making sure that those interventions are tailored to those practices or health systems, making sure that the whole team is included. And without a leader, that's really hard to move the needle without data and that leadership. So it is challenging sometimes to get doctors to pull, to have the time to lead these improvement projects, but their clinical and expertise is required, and we need that ability to have local leaders lead these projects. Next slide. This is an example of what one of our facilities has done to track blood pressure monitoring. You can see that they set their goal of controlling high blood pressure at greater than a 72%. And so this is a dashboard that they developed. This is the second year of a 2-year project for them. So their first year progress was not as green as this year. You can see that this graph is quite simple, and it does list each provider separately. The nice thing about things like this is that you can then also take, say you're looking at provider number 4, and you're like, well, what's going on with provider number 4? Well, if you've done some risk stratification, you may find that their patients are older and sicker. So it's a nice, although a dashboard is great and you want to have this kind of granularity in your data, to only solely be on a dashboard is something that is, you need to balance that a little bit. So I would encourage you to not only use a dashboard, but also other sources of data that you may have within your EHR, internal metrics, and things like that. Next slide. One of the respondents from the last evaluation that we did from our last webinar actually asked this question, and I thought this was great. It is really important to know what your goals should be in your data collection. So the ABCS, the aspirin, blood pressure control, cholesterol, and smoking, these are the core measures of most of the cardiovascular improvements that we're doing. And these are all listed in the quality payment program. If you are an FQHC or an RHC, perhaps you are using UDS measures. I don't have access to those particular measures, but your state primary care associations probably do. And working with them, you can see how you rate compared to the average. So you can see that for the quality payment program, I've listed the average performance from 2000, what was that, 19? And then what the 80th decile is. So 80% of the people that are submitting data, where they are in that. So you can see that aspirin obviously is probably the easiest to maximize your score in. Blood pressure control is, right at 70% to hit that 80th percentile. Cholesterol management a little bit higher, 83, and then your smoking assessment and counseling is between 70 and 80 to hit that 80th decile. So if you're already hitting those 70% marks, it might be time to shoot for the moon and go to the 90th decile or 9th decile, sorry, or as close to 100 as you can possibly get on things that are within your control. Next slide. This is just a graphic of, we all know the Plan, Do, Study Act, and this is just a graphic that kind of demonstrates that. So most of the organizations that are on this call have had additional training. Those resources and those fundamental aspects of quality improvement do not change regardless of the project that you're starting on. The leadership may change, the order that you do things may change, some of the community versus internal focus might change, but the overall process remains the same. And it's important that you use a systematic approach to your change management. Next slide. For those of you that do not have a standard resource or template to measure this type of work, HTS, Health Technologies, which was a part of Mountain Pacific and it's now been incorporated into Mountain Pacific, developed these beautiful templates, and they are still on our website. And I have them here, and you can use, I believe that's an active link once you get the slides out. If you have any trouble accessing it, you can reach out to any one of us and we can send you those templates. But there's more resources on our website for you to use standard procedures like this. And these forms are super helpful and adaptable to your individual situation. So one of the first things I like to do the change backlog procedure as a brainstorming exercise, and then use your project goals after you've had a little bit of a brainstorming. But there's no, you can do it either way, whatever works for you. Okay, next slide. The next step really for most people, most teams, is really to create those standard treatment protocols. A standard workflow prevents that clinical inertia where you say, oh, well, the patient had white coats, phenomena. We'll just catch them on their regularly scheduled appointment, and then that appointment doesn't occur for 3 months. Meanwhile, the patient has still under non-controlled blood pressure during that time period while you kind of decide if it's really hypertension or if it's just that the patient is nervous. So we don't want to use that white coat phenomenon to be an excuse to delay the diagnosis of hypertension and to start those medication regimes. Protocols can also standardize a ramped up approach to increasing the complexity of medication regimes and assess the adherence of the patient to what medication was prescribed. So often the protocols have if-then statements, a lot of flow charts that are super helpful. And the Million Hearts website does have a way that your team can create their own algorithm if that's what's needed, or there are several other examples of protocols / algorithms on the website that your team can just simply download and implement if you wish. Many, of course, need to implement these within their EHR, and then that's a whole different, kind of standard way that these things look. But these are some definite tools to have you have a leg up. Next slide, sorry. Not only is the clinical judgment can be standardized, but also the team care aspects can be standardized. What exact steps is the nurse or MA going to take? How frequently, how many blood pressures do they take at every office visit? Are they only going to do one and done? Or if the blood pressure is elevated, is there actually going to be 2 assessments of blood pressure spaced adequately apart? So this goes through a nursing workflow, which is awesome for consistency of training, reinforcing education, and making sure that the whole team is following the same procedures regardless of which provider a given nurse or medical assistant may be working with on any given day. So these protocols can vary greatly within an organization, depending, and then you can also include some of your EHR prompts that you may need to remind staff to do. So these team protocols are super helpful. Next slide. This is just, one of the next steps in the change package from the Million Hearts protocol was Million Hearts change package was simply to enhance team-based care. What does that look like? Well, team-based care can look like whatever you want your team-based care to look at. Are you going to focus on pre-visit planning so that patients are downloading their screening forms, bringing in their blood pressure logs, bringing in their medications? Are you going to focus on medication compliance? Are you going to focus on remote patient monitoring? These are all different types of interventions that are not solely dependent on the provider that's providing perhaps the prescription for that patient, but all the players that interact with that patient, which is the entire team. And every component of that is important. If the scheduler fails to reschedule the patient for their upcoming visit per the algorithm, then you've just missed an opportunity to catch somebody that has perhaps not been in complete control of their blood pressure. Next. Okay, so now it's your turn. We got about 10 minutes left. Go ahead, Maynette, and bring up our poll. We want to ask you what has been the most challenging aspect of your efforts to standardize care in your organization, your clinic, your facility. So go ahead and answer the poll. I'll give you a minute. And then hopefully we'll have some brave folks that will speak up and share what they have done. How are we doing for results, Stevie? Okay, well, let's go ahead and close the poll and see what our results are. Okay, designation of time and a provider champion. Step number 1, and that's the most challenging. So yeah, we have to figure out ways of compensating providers and ensuring that they have time to do this workflow. Anybody have any comments in the chat box that they can share, perhaps what their organization is doing to relieve that stress and allow physicians or even mid-levels to take on projects like this? I know we had the Million Hearts in Montana just had some presentations recently about some great practice. And there are some novel approaches to including team-based care and allowing nurses and pharmacists to help manage patients. So anybody, if you could raise your hand or speak up about anything that you've had successful in your organization, would love to hear from you.
There are several ways to chime in today. You can pop it into the chat function. You can put it in question and answer, or you can hit *6 on your phone to unmute. And Amber, it looks like we have our first question. Rochelle has said, we are embedding patient care advocates in provider offices to assist with identifying care gaps and referring members and patients to service coordination.
That's awesome.
Rochelle, that was awesome.
Yeah, and that really feeds your chronic care program so that you can bill for those chronic care management codes. You might be a primary care model where you are necessarily billing for those additional services, but either one of those can really assess patients' medication compliance, as well as make some of those needed medication regime changes and turf that up to the provider. Any other kind of feedback that we have from the group, maybe specifically about developing models for your physicians to have enough time to lead these projects? Because we realize it's not just hypertension that's a project. There's also other pressing issues, not only COVID, that your practices are addressing, but having that leadership, or at least an administrative support person that can help that provider, facilitate the logistics of meetings and things like that, so that the provider can focus solely on the clinical leadership and not necessarily some of the logistics. Ivy had just put in the chat box if there's sample models or workflows to share. The Million Hearts Change package has a gazillion of those sample models and sample workflows. The one that I placed on the slide was one that I personally liked the best as far as a supportive nursing MA role, but medical assistant role, but you can adapt those as you see fit. Let's go ahead and go to the next slide. Oh, well, I missed a slide there. Go ahead, go to the next one. Okay, so this is our leaving in action slide. And I just want to encourage each one of you to set an intention. I know with COVID, I can't even think straight about what I need to accomplish on a given day, but make a note for yourself. Try to make time to download the change package. Talk to, 2 members of your medical staff. If you're still trying to find a physician champion, you might be surprised that there's somebody that everybody asks for everything all the time, and maybe there's somebody that's a little less vocal that would love to manage a project or be asked to lead something. And what kind of assistance does that champion need? If your physicians are completely booked, what about a PA? What about a nurse practitioner? How can you include these other teams? Or if you have a clinical nurse leader, perhaps on your team, maybe that person can run the meetings and run interference with your provider. So just think of one action that you can do to make a positive difference, and write that intention down and commit to that action. Download the package, I think I already said that, and then just get a small group together. Start doing some brainstorming about things that you've seen work in other clinics. We are more than willing to have an affinity group of like-minded people that are trying to implement a specific intervention. If you have an intervention that you really want a smaller work group that is focused, like you're not going to be able to wiggle out of getting things done, put that in the chat box. Let us know what you think. Reach out to one of our team members, where we will respond via email. And I am at the end of my time, so I will let you guys all go. And I wish you health and mask up. Thank you very much for attending. Bye-bye.